I'm going to introduce Tim Henderson. We went to med school together, and he joined our practice about a year and a half ago. So thank you for all coming. He's going to talk to you about his anterior hip approach. We'd love to be able to do it at PCA and see you at PCA. It's great for patients. We have some patients here they're going to give their own testimonials. So we appreciate all of you coming, so thank you. And without further ado, Dr. Timothy J. Henderson.
So nice to see all of you. Many of you know me very well. Some of you don't actually know me at all. So I'll go through a quick biography of how I came here to stand here before you and do anterior total hips. First of all, I'm not a joint guy. I didn't do a total joint fellowship. It's kind of something I fell into. I did my residency at Emory University in Atlanta and did my fellowship at UCLA in sports medicine. And I joined Dr. Harper, my mentor, and he was a generalist, and he basically said that if you're going to have any success in private practice as a generalist, you have to do total hips and total knees. So I kind of looked over his shoulder for a year and learned how to do total hips and total knees fairly well. The money was no good in the practice, so I left Dr. Harper and took a job in southern Georgia, in Columbus, Georgia. And 2 months after I was there, the chief of orthopedics there, large hospital system, big trauma hospital, left. He was the joint guy. He had the 150 hips just lined up, ready to go, okay? So I became chief of the department. I don't think I stepped forward. I think everybody else stepped back, and I became chief of the department. And there were all these hips and knees that had to go, so I kind of plotted through and remember what I learned in residency and remember what Dr. Harper taught me, and it was great, but my social life was horrible in Columbus, Georgia. I'm a single black man in Columbus, Georgia, was not working out very well. Very high gold teeth to real teeth ratio, so I quickly made my move to go back to Georgia, and I started a place called the Rockdale Orthopedic Center, but the construction to build my building was 2 months late, so I'd already quit at Columbus, and then I had 2 months span. The rep that I was using for my total hip replacements picked up this new product called Medacta that works in anterior total hips. He said, look, man, we're going to teach you this. We can take you to Italy. We can take you to Denver. We can take you all these places. I said, free travel. I have 2 months. I'll never have this again. So I went off. I went first to Austin, Texas, learned how to do anterior total hips scrubbed in with Tyler Goldberg. And this is when I became skeptic to believer, because these guys are telling me these people are walking without crutches within 6 hours. There's no dislocation precautions, and coming from where I came from in residency, it sounded like hoopla. It sounded ridiculous. So I saw Dr. Goldberg do some hips. These patients were literally without crutches or without walker in 6 hours. No dislocation precautions, nothing. So I was a believer. So I went off to Italy, saw the company, went to Switzerland and worked with Dr. Dorr, who's done 3,000 anterior total hips, and he does about 12 a day by noon, because he has a team, and they have these ORs. They just roll people out, and the residents set them up, and he just does the procedure, which was incredible. So after that, I was sold. My son was coming. I decided to come back to New Jersey to get the free babysitting, because I was born up here, and took over the chief position at Lourdes. Couldn't do outpatient total hips because 90% of my people were Medicare and Medicaid. And they don't really believe that we exist yet. So I tried to do total hips as much as I could on my private insurance patients, and then Sean found me. We dated for a while before I decided to join Gotham. And once I got here, I was so excited. Private insurance, we're going to do total hips. I run into Beth Israel Hospital. Dr. Kastenbaum, we're going to do total hips, outpatient total hips. And he's like, oh, son, we don't do that type of thing here. We don't, he basically shut all the jets on any outpatient total hips. So we went and found better grounds in New Jersey, and we started at Mountainside. I think I did my first few outpatients at Mountainside, and then we found more fertile ground at St. Barnabas. But still, at St. Barnabas, it's a hospital. So we have to deal with, I rush in eager every Friday, 7:30 in the morning. I want to get at least 2 or 3 outpatients done. And so we get, 7:30 start time means 8:30 cut time. We get the surgery done about an hour and a half. Patient's out of the room by 10:30. My next patient comes into the room at 1. Okay? And so, so I'm sitting there watching, sitting in this time-sucking vortex and trying to figure out a way to get out. So this is why I'm standing in front of you today, because I'd like to find a more efficient way to get this product out to my patients. Anyway, without further ado. You already went through the first page. So, outpatient total hip replacement. So back in 1991, 92, the average length of stay for a total hip replacement was close to 10 days. 2007, 2008, we got it down to about 3.7 days. Nationwide right now, it's anywhere, depending on who you ask, between 2.5 and 3.4 days. And it's been decreasing and decreasing and decreasing, and all my patients generally go home within 24 hours of their surgery, and I try to get everyone who has private insurance home within 6 hours of their surgery. So the next, that's the sign. The next natural evolution of hip replacement and total knee replacement eventually will be outpatient surgery. And we've been here before. So back in the olden days, arthroscopy, they would admit patients. ACLs, and I actually, I guess I'm old enough to remember when they did ACL reconstructions. My cousin had the ACL reconstruction when I was in high school, and by the doctor for the New York Knicks, and he was in the hospital for 2 days. He was on the PCA, a CPM. Rotator cuff repairs used to be inpatient, all types of foot and ankle surgeries, and of course discectomies. So we've been down this road before where it's gone from inpatient, you're here for several days, to outpatient management, and this will be the natural progression of arthroplasty. So how did we get here? How do we evolve from 9 days to 3.7 days to 1 day to now 4 hours to 5 hours in the hospital? Well, it's a refining of everything we do, not just the surgical technique. We've refined the way we select patients. Of course, we've refined the way we do our anesthesia protocols, because pain is one of the main limiting factors in getting people home. We've refined our surgical techniques, and right now we can do total hip replacements without cutting any muscles or any tendons. We've found a way to do that. And we also have rapid recovery protocols postoperatively. So the first and foremost, most important thing is patient selection. And these are rules I always find myself breaking, because, I used to say 70-year-olds and younger, and I see 79-year-olds walking through who are fit as a fiddle, who want to go home as soon as we're done with the procedure. No revision surgery, of course, because they're completely unpredictable. You don't know if you're going to be there for an hour and a half or 4 hours, depending on what you find. No history of a heart attack within 1 year. This kind of goes into the common sense reason we don't do outpatient. People with unstable angina or solid organ transplants, obviously. No patients with more than three major medical morbidities. And one thing I don't break is the BMI over 40, because I used to do anterior hip replacements and minimally invasive hip replacements on everybody, and I've learned the hard way that once you go over 40 on the BMI, your results go down and you end up in trouble. So this guy right here, I'd have trouble, he'd have trouble convincing me to go with the outpatient or anterior hip replacement. Go ahead, and I'll show you. This is one of my Columbus, Georgia patients right here. That's how they look down there. So that's actually the back of someone's head, but all right. But reminiscent. Next slide, please. So the anesthesia protocols, and this is why I like the anesthesiologist to be here, because you're literally probably the second most, very close second, but the second most important person in the surgical procedure. Medical optimization is essential for safety and success of outpatient total joint replacement, and that starts with prehab, where the first thing you have to do is you have to take your patient and tell them that you're going to be doing an outpatient total hip or total knee replacement. Because the patient has been told by their friends, their aunts, their grandmother, their physical therapists, other orthopedic surgeons, that this is an inpatient procedure and is best done as inpatient. So you have to basically deprogram these people to realize that this is done regularly and safely as an outpatient. And that's the first thing you have to get across. And that will actually motivate your patient. It's good to have a pre-op site visit, either at the hospital or the ambulatory surgery center, because that relieves some of the trepidation that the patient has in the morning. Am I going to be late? How am I going to get there? Am I going to be late for this giant procedure I have? And crutch training and home exercise training prior to surgery really helps as well. Go ahead. So this is what I call preemptive anesthesia. So in the PACU or in the morning of surgery, we try to basically get in front of the pain cascade before it starts. We start with Celebrex, which helps relieve inflammation, Tylenol, which works on the pain cascade, MS-Contin works on the pain cascade, Neurontin works on nerve irritation, as you know, and a steroid works on inflammation, which all decreases the pain before we even get started with surgery, before we even touch the patient. The anesthesia protocol, we do antibiotics per skip guidelines. In my hands, if you don't have a penicillin allergy, it's 2 grams of Ancef and 80 milligrams of gentamicin to sterilize the bladder. Single shot Marcaine spinal anesthetic. This is very important because to do the hip replacement that I do, which is completely muscle sparing, you have to have very flaccid muscles. You have to have complete muscle paralysis. If the patient has muscle tone, it makes it very difficult to do the procedure. You end up working harder, damaging more muscle, creating more tissue, inflammation, pain, and the patient may not be able to go home. Tranexamic acid has been a godsend for me because blood loss that used to just free flow and you watch the bone leak after you make your cuts, it doesn't happen anymore. So my blood loss is basically around 150 cc's per case. We don't really transfuse people except in very exceptional instances. Intraoperatively, we give them Zofran because nausea and vomiting can actually cause people not to go home, and Toradol, once again, to affect the pain cascade. We avoid the use of IV narcotics. This way? Sorry. We avoid the use of IV narcotics because if you have a patient who's very, dopey and tired and narcotized after surgery, it makes it very difficult for them to get up and participate in physical therapy. And we keep them well hydrated because we don't want to deal with orthostatic hypotension after the procedure. So we like aggressive hydration from our anesthesiologists. So anesthesia per the surgeon, okay? Well, minimally invasive anterior supine intramuscular approach, also known as the AMIS approach or the direct anterior approach, is the first anesthesia I provide because I don't cut through any muscles, I don't release any tendons, not even the rectus femoris. The only structure I'm actually cutting that I have to repair is the anterior capsule of the hip. So without disturbing or destroying those muscles and tendons, you're gonna have less pain. At the end of the case, I inject Exparel, which is a liposomal suspended Marcaine, which is supposed to be long-acting. The results are pretty good. They're not perfect. I mix that with 0.25% Marcaine and 60 cc's of saline. So I have 100 cc's of fluid to inject about the hip. I inject it in the capsule, in the tensor fasciae lata, in the rectus, in the subcutaneous tissue, and near the skin prior to closure. I use Evusil at the end of the procedure to help prevent blood loss or hematomas. So once again, the anterior supine intramuscular hip replacement is a hip replacement that's anterior, 10 centimeter incision on the anterior aspect of your thigh. We cut through no muscles and no tendons whatsoever. I use a table extension, Othello. I was involved in the design of that device. It's the only device in the world that actually protects the knee while you do the extreme external rotation of the leg that you need to get to the hip. And it allows me to do a total hip replacement with only having 3 people in the room: the surgeon, the first assist, and the scrub tech. I don't like anybody else in the room because everybody who comes in is shedding bacteria. So I like to keep the room fairly empty for the hip replacement, and this allows me to do this without much help. So there's several different approaches to get to the hip. There's the anterior, anterolateral, direct lateral, lateral trochanteric, posterior lateral, posterior, and they all have minimally invasive techniques. But the anterior supine intramuscular technique is the only one that works without cutting any muscles, none. So the way I learned hips when I was in residency basically was the posterior lateral technique, and it usually involves a 15 centimeter surgical scar. Okay. Dissection through muscle, which can cause a limp. Okay. You have dangers such as the sciatic nerve, the inferior gluteal artery, as you're doing the procedure. Okay. You also have the dreaded posterior hip dislocation. So what the physical therapists are used to telling patients is, oh, after surgery, you can't sit down in a deep toilet seat. You can't bend your knee past 90. You can't sleep with your leg crossed over the other. You have to sleep with a pillow between your legs. What I tell my patients, if you can do the splits in the PACU, you can do the splits. You cannot dislocate this hip because after I disconnect you from the table device, I can't dislocate your hip. So the minimally invasive anterior supine intramuscular approach is the only technique that we know of that is intramuscular completely and internervous. That's what my incision looks like. So this is a great picture. So that is the picture of actually a metal-on-metal acetabular cup going in. And you see these kind of retractors around. I've gotten so kind of meticulous about my soft tissue technique, I don't even use retractors anymore. So I don't use retractors that go around the acetabulum anymore. I use spine retractors that spine surgeons use to spread the muscle apart because I believe digging acetabular retractors around the acetabulum causes irritation and pain that I don't want my patients to have so they can actually go home fairly comfortably. This is what it looks like when our femoral stem is going in, and that's basically the size of the incision. So once again, Minimally invasive anterior approach that we utilize for our total hips. We don't cut through any muscles. And this kind of shows the trick. If you look here, that little squiggly line is how we dissect through. Right here, you have a muscle called the tentor fascia lata. We basically dissect through that fascia, pull that laterally, and block the entire muscle. We then look at the rectus fascia. We dissect through that very gently and retract the rectus muscle medially. Then we're left with the innominate fascia. We gently dissect through that, ligate some very large vessels. And once we cut through those vessels, we're staring at the front of the hip capsule. We make our V-shaped capsulotomy, do our hip replacement, and get out. And when we take our retractors out, the muscles literally fall back over each other, like you weren't there. So you heard about Othello, or I talked briefly about Othello. I'm not sure if I mentioned anybody. That's the name of the table we use, but we call it Othello because it's anterior total hip equal leg length operation. We already talked about the anterior total hip of it, so how do we get the limb lengths? Because this is the most important thing for patients postoperatively. They want to feel that they're completely equal. Well, hit the button. We cheat. So hit it again. Throughout the entire procedure, we're using C-arm fluoroscopy. So I basically look at the good leg, look at the offset, look at the length, and then I go back to the leg I'm operating on. Until they're exactly mirrored, I don't leave the operating room. So we make sure our limb lengths are perfect every single time. There's, because previously we were doing things like the shuck test and other tests which are completely subjective. I like objective information before I decide the hip looks well. Rapid recovery protocols. So in the PACU, the post-anesthesia care unit, you get 4 milligrams of IV Zofran for nausea, prevention of nausea, continued aggressive hydration. MS-Contin, we start about 2 hours post-op. Percocet, which is 10 by 325, is which I send my patients home on, 1 to 2 every 4 hours. DVD prophylaxis with SEDs while the patients are in recovery. And post-op day, we use aspirin, twice a day, high dose. And also we use ice. One of the biggest things, one of the most important parts. I want to make sure everybody's still awake. The 80s. So one of the most important, ice is nature's safest anti-inflammatory. We apply it 20 minutes on, 20 minutes off as much as we can, and patients seem to do very well with that. So physical therapy begins 4 hours post-op or as soon as the marking spinal wears off. Weight bearing is tolerated with assisted devices as needed or not. I can encourage my patients to go on to not using their assisted devices as soon as they feel stable. We give a final dosage of IV antibiotics after they finish physical therapy and prior to discharge. Discharge planning is done. We like patients to be at outpatient or home physical therapy post-op day 1. Ideally, patients come to our physical therapy center the very next morning. That gives me another set of eyes on the patient that I just did a major procedure on. Basically, our discharge planning team works on getting any needed DMEs, walkers, crutches, canes, or travel assistance as needed. I really recommend the patients go to outpatient physical therapy at least starting their second week if they didn't do it right away, because home physical therapy is often very lax and very lackadaisical and gentle, where I want people in more aggressive physical therapy. So for outpatient total joint replacement and in my hands hip replacement, close follow-up with outpatient total hips is essential. The patient's either seen with our physical therapy department post-op day 1, or ideally contacted by a member of our team post-operative day 1. And the patient will be seen in my office in 72 hours for a wound check. If the wound looks good, I don't take it down. It'll never be cleaner than when I put it on the operating room. And I'll bring them back at 10 days to take their staples out and put steri strips on. So, who benefits from outpatient total joint replacement programs? I think everyone does. Certainly the patients like to be at home recovering with their families. The payers, if they have less time in the hospital and less resources to pay for, it'll be much less expensive. Surgeons, I don't know anybody who likes rounding on the weekends. I certainly do not. And if we're investors in the surgery center, that helps us as well. And of course, ambulatory surgery centers and hospitals, but that's the reason why we're here. We can hit the button. Little Batman. All right. So it's clearly shown that patients enjoy being at home for their recovery more. They can recover in their own home surrounded by their family. It's just simply more pleasant. And in my opinion, shorter exposure to the VREs and the MRSAs of the world was good for any joint replacement or any surgery that you have. Payers. So the shorter length of stay can reduce the cost for covered lives. Costs, and they're going to catch on at some point. But they're going to realize that we can do it much shorter, so they're going to decrease our pay. But currently, the way we're getting reimbursed now, we can really have, a good sweet spot, because they'll pay the full amount for a total hip, and we can do it for much cheaper. And in the ambulatory surgery center, total hips or total knees can be as little as a third of what they cost in the hospital. Things are going to be changing shortly with the CCJR, which is the Comprehensive Committee on Joint Replacement, where they come in with bundled payments. That might be a good thing, or that might be a bad thing. It's going to be hard to see. But if in our area, people are, we come in the bundled payments and they're paying $45,000 for every hip, we're able to do the entire procedure, everything for $20,000. Obviously, it's going to be good for somebody because only a $45,000 check comes. Surgeons. On the inpatient side of medicine, it's becoming more burdensome on what we can do. There's so many rules and regulations in the hospital that I almost can't act as a surgeon sometimes and make my own decisions. So if we put these hip replacements and knee replacements eventually in the ASC, some of the control of the process goes back to me. The enhanced efficiency of the ASC will definitely improve the efficiency of your practice. For right now, we can get two outpatient total hip replacements done a day. My dream is to get 3. In the ASC, I'm sure we can get 6 by noon, which makes your practice much more efficient. And now, of course, the limited inpatient rounding. Nobody likes to wake up on Saturday morning to go to the hospital to, no offense, patients. But nobody likes. No, thanks, guys. Thanks, fantastic. All right, ambulatory surgery centers. So obviously, ASC joints, like I just said, are actually cheaper than the hospital. ASC-based joints are more profitable for ASC invested physicians. I think that we're not completely money oriented. That might be inappropriate. Go to the next one. Next one. That's probably more like it what we're thinking about. Right. So go to the next one. So in conclusion, implementing a successful outpatient joint replacement program requires perfect execution, a refined, comprehensive approach with the willing and able team members, and motivated patients is required. In the area, any part of the process can result in the failure of the outpatient goal. And that's the presentation for tonight. I can come up here and tell you guys anything, and I can say I'm the best thing in the world, but the proof is in the pudding, and here's some beautiful pudding right here. Here's some of my patients. We have Robert Napoleon, Wendy Kaplan, and Robert Hess, who are all, Wendy, she was the first outpatient total hip replacement at St. Barnabas. You have anything to add? Would you like to come up and do a little jig?
What would you like to know? I would basically say, stand up, basically say that it was...
Tell them about your experience, how long you were in the hospital, and what you experienced as a patient.
Right. I didn't even stay overnight. It was same-day surgery. Prior to this surgery, I was in a lot of pain. At first I thought it was a hip flexor, but I couldn't do anything other than parallel. I exercised, and as a matter of fact, I exercised up until the day of the surgery, but I couldn't do any kind of turnout. And even going up the slightest incline was painful. When I saw Dr. Henderson, at first I thought that I wouldn't be able to do my exercise anymore. I do something called the bar method, which is pretty strenuous. It's a combination of ballet and Pilates and everything else. So you do leg up on the bar and everything and splits. And he said, I would be able to do this afterwards. I'd be able to wear high heels. I could go back to everything. So once I heard his presentation, it was so convincing, and my husband's a doctor. I just decided to do it immediately. There was no point in waiting. And I walked off the operating table. I went home. 2 days later, I went to a concert performance that my daughter was in. I was on pain medication for 9 days. Toward the end, it was more preventative. My husband had said, do you really need that? And I realized I didn't. Then I went on to Tylenol. I can't take anti-inflammatories because I'm celiac. But I was fine. And within 2 months, I went back to my exercise class. I can do splits now. I can do...
Did you guys hear that? Anybody does joint replacement in here talking about patient doing the splits? I
can do a split. I can do all sorts of things. And it was really a godsend. I found that, in all honesty, Dr. Henderson relieved a lot of anxiety and made it very, very comfortable. And the whole experience was amazing. I've had foot surgery, and this was 10 times better. 10 times better. So the recovery was easy. It was really, really easy. And I'm a big fan of this.
Appreciate
Do you have
it.
any questions from a patient's point of view? Anything you would want to know?
Were you awake during surgery?
Was I awake? Was I?
You were. So she had Verset's a hell of a drug. Little Versed and propofol kind of wipes the memory bank fairly clean.
Right.
Thank
Any
you.
other questions?
We're a stoic group, doctors, you know.
Okay. But I mean, you could reassure patients. I mean, it's definitely something that I would recommend.
How'd you do that?
And I like the idea of going home and not staying in the hospital.
We have Robert Napoleon here. He is a Secaucus police officer, and he was worried about getting back to work fairly quickly.
Evening, folks. As Dr. Henderson said, my name is Robert Napoleon. I've been a Secaucus police officer for 17 years now. I started to experience some pain in my right hip probably back around 2012. And just attributed it to daily activity, things I was doing, working out, etc. Eventually, pain got to be so bad that in going to my doctor, he had started to prescribe me naproxen. I was up to about 1,400 milligrams a day of the time-release naproxen, which is, I think, the most you're allowed to take.
Yeah, 20. Yeah.
And that was basically just to be able to function. It's still in a tremendous amount of pain. Well, fate actually brought Dr. Henderson and I together. My son had a bit of a mishap and broke his ankle. Dr. Henderson worked on my son. In bringing my son back to Dr. Henderson's office for follow-up visits, I discussed my situation and my pain with Dr. Henderson. And one thing led to another. Before I knew it, I was having my hip replaced. As a police officer, I was extremely worried about the possibility of my career coming to an end. I had only been on for approximately 20 years with the state at the time, and maybe 14 years with the town, which would not have been enough for me to retire at any kind of a decent pension and medical. Worried about my family. I had 3 children, a wife, a home, many expenses. I honestly just can't say enough about what Dr. Henderson did for me. In talking to folks about what to expect, they were telling me I would be out for probably 3 months. I might have to go on disability. I didn't know how I was going to pay my bills, keep up with finances, etc. Dr. Henderson put all that stress and worry at ease with me in talking to me about the procedure itself, how long I would actually be out of work. The procedure itself was phenomenal. I spent 1 night in the hospital, and that was only because the procedure was performed at such a late time in the day.
He was the 3rd case. That's the situation. So the time-sucking vortex got us. So
I went home the next day without problem. The recovery period was phenomenal. Rehabilitation was basically painless. The procedure itself, I'm just absolutely amazed. I was out of work for 22 sick days, less than a month worth of sick time.
I went back to go tracing bad guys in 22 days.
Yep. Light duty for 3 weeks, back on the road, full duty. Amazing, absolutely amazing experience. And relatively, no pain. I just about used any of the painkillers that he had given me. I really pretty much used ibuprofen that I purchased over the counter. I followed everything he told me to do, icing, heat, exercises, etc. Even the folks at Kessler, where I went for my rehabilitation, were amazed at my abilities so soon so soon after the procedure and how it was performed. But again, I truly owe my life to Dr. Henderson.
He took me fishing. We're even. Took me fishing up in Pulaski.
We have a lot more to do.
That's it.
I do. I owe my career and my life to Dr. Henderson in what he did for me.
I appreciate
Me
that.
and my job, being able to provide for my family, and actually make it to retirement. I'm deeply indebted to Dr. Henderson.
If I could blush, I'd be blushing.
Tremendous experience.
I appreciate that, Robert.
Also, in talking to some of the other patients, we come from what appear to be a few different age groups. And this particular procedure seems to be applicable to all of us, quite honestly. I could almost call it a universal procedure for age group. I really, really could.
Robert, you wanna get up here and throw your 2 cents in? Another Robert?
Thank you.
Thanks, Robert.
We're speaking about the young people over here. This year, April 20th, I turned 80. And end of January, Dr. Henderson performed surgery on me. I stayed overnight, he said, because of my age.
In Medicare.
So the next morning, they woke me up and the physical therapist came in and said, we want you to walk down the hall with us. And I thought they were crazy. I got out of bed slowly, and they gave me a walker. We walked down the hall, I walked back a few times.
Hey,
Back
thanks,
to
man.
bed. That afternoon at 2 o'clock, the physical therapist came back and said, I want you to walk with me with the cane, not with a walker. So I got up with the cane, walked around the hall, they took me out to the stairwell, went up and down the stairs several times. I was amazed by it. And by the way, when I went through the procedure and came out of the procedure, absolutely no pain whatsoever. I mean, absolutely none. To this day, I have no pain.
Have you used any pain meds?
No, actually, he gave me a prescription for it, and it's still in my drawer at home. I never used it. I think we did aspirin twice a day for a month, and that was it, basically. And I got to Dr. Henderson only because several friends of mine went through the procedure from the backside. And when I seen what they went through, and the pain and the agony that was caused by it, I was not going to have my procedure done at all. Till I saw the article in the magazine, and I think you were in that picture. And I said, I want to speak to her, because I want to speak to him to say, how is this? Is it possible? Because everybody I talked to, no one heard of it. It was totally unheard of. So I wound up interviewing with him, and then when he called me the procedure, I said, we're going to go do it. Now the people that I knew that had it, or personal friends of mine, I told them my experiences, they thought I was crazy. Even my eye doctor had his hip done. And I just went for an eye checkup, and he said to me, hey, guess what I just had? I just had my hip replaced. He goes, oh, really? He goes, how was it? I said, absolutely no pain. He just stopped at what he was doing. He looked at me very seriously and said, are you serious? I said, Doc, I had absolutely no pain. I was up walking the next day. Matter of fact, from the hospital, I took a walker, walked out of the hospital with the walker, walked up my driveway with the walker, and never used it again. That's the remarkable thing about what he's doing here. And I'm still convinced that we got to notify people that this procedure is out there. And I congratulate PAC for tying in with Dr. Henderson. And you obviously have the foresight. And as soon as the public is aware of this, or JAMA or somebody can give him the exposure he needs, he'll have a line waiting outside his door. And you can't thank him enough for that and his expertise. As you say at PAC, you take care of the patient, and they'll come back to you all the time. And this man, I gave the card to so many people. Physical therapy, I went 6 sessions. And there was a gentleman there I met. His name was Mike Martin. And we're sitting together, and he said, what'd you have? I said, I had right hip replacement. He said, so did I. He said, who did yours? I said, Dr. Henderson. Oh, he goes to me, I wanted to go to that guy. I interviewed with him. I was convinced I was going to use him. He said, I went back to my doctor, told him who I was going to use. He talked me out of it. He went to special surgery in New York. Now, here we are together in therapy. I was finished and done in 3 or 4 weeks out playing golf. He's a golfer. He hasn't been able to touch clubs yet, and he won't be able to do it for 30 more days. So he looks at me and he's frustrated. And he realizes now he made a terrible mistake. But unfortunately,
You're hired.
You're hired. So, Dr. Henderson,
Thank you. I appreciate it. Thanks, Robert. Tired. If there's any other questions, I'm here. But if not, enjoy your meal. Thanks for coming and listening. And hope we can bring this product to PCA and do some work. It'd be great. Thanks, guys.
Thank you.
Thanks, guys.